the left shows you normal red blood cells. They live about 4 months. This is why people with sickle cell disease, it's called anemia, and anemia because these sickle cells don't live as long as a normal cell. Now what happens when you get a bunch of these sickle cells in the blood vessels of the person who's suffering with the disease is they can clump together and block blood vessels. And this is what causes the problems with this disease. How do you get it? It's not contagious. You do inherit it. Both parents have to carry an abnormal hemoglobin trait for to have a child with sickle cell disease. And the cartoon on the left shows you 2 parents with sickle cell trait. A is your normal adult hemoglobin, S is sickle. And between those 2 parents, they have a 1 in 4 chance of having a child with normal hemoglobin because you inherit one trait from one gene from each parent. And so if you get 2 normal genes from the parents, you have a child who's normal. If you get 1 normal and 1 S, that's sickle cell trait. Sickle cell trait people are not sick usually. And then you have a 1 in 4 chance if the child inherits an S gene from both parents. That child is born with sickle cell disease. And this picture shows you SS. That's one form of sickle cell. Now, on the right, we have a parent with sickle cell trait, have a parent with hemoglobin C trait. Hemoglobin C is another abnormal hemoglobin. Not like sickle, but it is abnormal. And so if you combine, if that child gets 1 sickle gene from a parent, 1 C gene from the parent, that child will have a form of sickle cell disease SC. So I like to show this slide to show you that both parents do not have to carry the sickle cell trait for a child to be born with sickle cell disease. Most people aren't aware of that until they have a child with sickle cell disease SC or some other type of sickle cell. This shows you the variants you can get with a combination of your sickle gene. You can have sickle cell disease as S. There's SC, there's an S beta plus thalassemia, S beta 0 thalassemia, there's an SD, and then any form, SE, any other, there's hundreds of abnormal hemoglobins. If they combine with the S gene, you have a child with sickle cell disease, or a person as they grow up. I say child because I am a pediatric nurse, so I come from that background. It is most common in individuals of African descent. However, it's not exclusive to people of African descent. 1 in 12 African Americans have the sickle cell trait, and about 1 in 500 African Americans have sickle cell disease. In Oklahoma, where we do newborn screening, we have about 15 babies a year born with sickle cell disease. You do see sickle gene in different parts of the world. The origins, I think, were Africa, the Middle East, southern India, the Mediterranean, which includes Greece and Turkey. So you will see sickle cell in individuals of all ethnic groups, all races. This map just shows you, the little dots show you where they think the gene mutated, and then through Africa, parts of Europe, and through slavery, through migration, you now see sickle cell in this part of the world. This just shows you some kids with sickle cell. They come in all shapes and sizes, all races, all ethnic groups. So what happens when a person has sickle cell disease? Well, when those blood vessels get blocked by those sickle genes, it really affects the whole body. They're more prone to infection, specifically bacterial infections. They have pain crisis because when that blood vessel gets blocked, that area is not getting enough oxygen, and that causes pain. Their spleen is damaged, which early on, as early as 2 months of age, which makes them more prone to infections. They have lung problems, they have anemia, they get kidney damage very early. Some children have strokes. They get gallstones very early in life. If you know someone with sickle cell, you may notice sometimes they may be jaundiced, which means their eyes are yellow. That's because their blood cells are breaking down so fast. They get sleep apnea. We have little children with sleep apnea. I'm sure most people have heard of it. But we have lots of little children whose tonsils get so big that they can't sleep at night. And that makes their disease worse because they're not getting enough oxygen. They can have problems in their eyes. As they get older, they can get leg ulcers. Some of the children are developmentally, they don't grow as fast as other children. They do reach a normal height for their genes, because you inherit your height from your parents. Sickle cell does not affect that. But they may grow a little slower, develop a little later than other children. And as they get older, they get problems in their bones and their joints. This picture shows a typical early pain crisis in a child with sickle cell disease. It's called hand-foot syndrome. Their hands and feet can swell. And you can see it looks very painful. This is probably the first pain crisis most children with sickle cell will have at about 6 months of age. And it's something that can be very painful. We treat with pain medicines, fluids, but that's just one of the, actually pain is what brings most people with sickle cell to the hospital. Because sometimes if you can't handle this at home, most pain crises you can handle at home, but if it's very painful, then they have to come in for stronger medications. And some of the symptoms we like for our patients to come in right away for, of course, it's fever, our first sign of infection. So if it's 101, we teach parents you have to go right away to the doctor, 24/7, doesn't matter, they have to come in. Severe pain that you can't manage at home. If they seem more tired because they are anemic, sometimes they can be more tired than usual because their blood cells are breaking down faster, or they're not making blood fast enough, so they need to come in for that. If they look paler, or if their abdomen suddenly swells, which could be problems with their spleen. Or sometimes in our school-age children, we see a sudden change in their learning ability, and that can sometimes mean a silent stroke. So we ask parents if they notice that, if suddenly they can't complete their work, they can't remember what they're doing, they need to come in. Sometimes you can find that they've had a silent stroke. And of course, an overt stroke, they would come in right away anyway. So those are the main, really some of the basic problems that happen. Some of the treatments we have now for sickle cell, hydroxyurea, which is right now the only drug that's approved to treat, which can actually decrease the sickling that they're having. That's the drug we're using. The only cure for sickle cell right now is the stem cell transplants, but they have to have a match from a brother or sister that's a complete match. So a lot of people aren't eligible for this cure. And then there's gene therapy that we're working on to try to do some things before the child is born, or after, I guess, to change the type of hemoglobin they're making. And then there's, I'm not ready to do that one yet. But it says there's no cure, but there is a cure, but not many people can take advantage of that. But we can treat the complications. So we try to have the parents bring the child up to be as normal as possible because they are going to grow up. Now, people with sickle cell, because of the treatment and research, are now living beyond the age of 45. And so they're going to grow up and they're going to get jobs, so they need to probably have families. So they need to go to school, try not to use their disease. If they're sick, they truly, if they're truly sick, yes. But we try to encourage them not to use their disease as a way to get out of doing things. Just regular follow-up with their medical team and just be as normal as possible. So basically, that's where we are. I am from the Oklahoma Pediatric Sickle Cell Program. We're located in the Jimmy Evans Center for Cancer and Blood Disorders in Children, OU physicians. We are our sickle cell doctors, Dr. Joan Parkhurst-Kane. I'm Annette, I'm this nurse. My colleague Delphine Dorsey is here. She's our transition nurse. She actually helps our patients reach the age of 21. She helps them get into with adult doctors. There is no adult program, but she does a good job of getting them with somebody. And Christina Gonzalez is our clinical research associate. And now, I think we'll just go on with Dr. Broyles. If there are questions, we can take them after that. But Dr. Robert Broyles is here, and he has been working on a cure for sickle cell for well over 30 years now, I think. And we think he's very close, and so we hope that you'll make a nice donation so he can continue his work. Dr. Broyles.